Hi, good morning, everyone. I'm Karen, the Department Manager of Respiratory and Critical Care, Singapore General Hospital. Thank you for spending time with us this morning to learn more about chronic obstructive pulmonary disease, COPD. It's never too early, never too late to quit smoking and get tested. I would like to first thank you for all our sponsors and of course, people who attend our webinar today. And we have a few speakers in line. Okay, so first, I would like to introduce Dr. Chiu Si-yuan, consultant of Respiratory and Critical Care Medicine, Singapore General Hospital. He will be doing the opening address and followed by his topic, what is COPD and how do I get tested? Si-yuan, please.
Thank you very much, Karen. Thank you. Good morning and a warm welcome to everyone. Today we have an exciting lineup of talks from our COPD team comprising of doctors and nurses and physiotherapists. And this will be followed by a question and answer session, free and easy. And today I would like to start by sharing this year's World COPD message. Let me share my screen. Let me know if you can't see my screen clearly. Okay. So this year's theme for World COPD Day would like to highlight the importance of lifelong lung health. Every one of us is born with only one set of lungs, and when we are born, keeping our lungs healthy is an integral part of ensuring that we have good health when we are in our older years. Today's webinar will focus on contributing factors from COPD and what we can do to promote lifelong lung health. As what Karen has mentioned, I'd like to acknowledge support given by our sponsors, AstraZeneca, GlaxoSmithKline, Hyphens Pharma, and Oren Yuo Pharma. Without their support, today's webinar would not be possible. I would like to share that for those who can't join us for the whole session, a recording of today's webinar will be made available in our SGH YouTube channel. So do you know that in COPD patients, many patients have had a hospital admission, and some of them even die very soon after hospital admission? COPD is a major cause of death in Singapore. And in fact, this is old data, but in fact, this used to even rank above diabetes mellitus. So what is COPD and how do I get tested? COPD stands for Chronic Obstructive Pulmonary Disease. All right. And I'll first like to share how our amazing set of lungs work. Okay. I put up some diagrams of how our lungs look like, how they work. On the left, you can see, a lung that's filling out with air. So air first goes through our windpipe and airways and finally into the lungs. And our lungs are made up of many, many small air sacs we call alveoli. And it is within these air sacs where the remarkable process of gas exchange happens. Blood from our body goes through all these little microscopic air sacs, and oxygen is absorbed and carbon dioxide is released. So these lungs actually give us oxygen no matter where we are, whether we are on a plane, whether we're on a mountain, or whether we're in Singapore. And here's an amazing fact about lungs. Do you know that the surface area of all these air sacs, if you lie down on the ground, is equal to the size of a tennis court? And that is amazing because we actually have so much lung reserve that it's only when we have severe illness and severe disease do we truly get sick. And this is often the reason why many patients with COPD actually don't get diagnosed early. Our lungs have tremendous spare capacity, and significant symptoms only appear when we lose a lot of lung function. In fact, when we see patients with lung cancer, some patients actually undergo a removal of their lung for surgery, and they're still able to lead a normal life even with one lung. So we are actually given two lungs in our life, and for us to get symptomatic with disease means that we have not just one but both lungs getting severely affected. Okay, so what causes COPD? All right, I'm sure most of you know that the number one cause of COPD in this world is cigarette smoking. And cigarette or tobacco smoking come in many forms. All right, for the older generation, you may recognize Ang Hun or rolled cigarettes. For the younger generation, you may also recognize shisha piping or smoke. And this is something that Singapore has kind of tried to disallow in our country. Pipe smoking, and more importantly, we are easily recognizing the role of air pollution in causing your COPD. Right? I'm sure all of us are familiar with the haze. And many years ago, our pioneer generation, many of us might have actually prepared meals by having indoor wood fires, charcoal fires, for heating and for food preparation. If one prepares food or cooks with wood fires, in an enclosed area with poor ventilation, prolonged exposure to smoke in these environments may actually lead to COPD over the long term. Okay, this is how a lung with COPD functions. On the left, you can see that this is a normal windpipe. Okay, air travels from our mouth and nose into our lungs via a windpipe. And normally our windpipes have a normal lining with a normal amount of mucus. Okay, when we have excessive and prolonged exposure to smoke, the smoke causes deposition of toxins and tar and poisons that actually cause inflammation in the windpipes. All right, and this actually results in swelling, inflammation, and excess mucus production. And this all leads to narrowing of the windpipe and the airways. And this results in one of the symptoms of shortness of breath, wheezing, and chest tightness. Similarly, you can also see that in our lungs, all right, the air sacs that I described about, the ones that give us a tennis court space of surface area for air exchange, okay, these actually get damaged as well. And this results in trapping of air in the air sacs, and this also contributes to symptoms of COPD. As mentioned, these symptoms include cough and phlegm, shortness of breath, wheezing, and chest tightness. Okay. Now, unfortunately, once the changes in the patient happens in COPD, these are permanent, and therefore prevention is always better. So for those out there who smoke cigarettes, we strongly advise that you try to quit smoking, if not reduce your smoking. And later on, my colleague, Dr. Ken Lee, will be sharing with you how we can help you in your quit journey. All right. Now, we call these changes of COPD emphysema. Okay, it's a difficult medical term to pronounce, but let me share what it looks like. All right. Now, a person with emphysema actually has little bubbles forming in the lung. All right. On the right here is a picture of a patient undergoing lung surgery. And some of these bubbles can become so big, we call it a bulla. And this bulla can actually rupture and result in air leak of the lung. And patients who have this have to get hospitalized. Okay, if we do a CT scan, which is shown in the middle, you can see that there are actually air bubbles, all right? And these air bubbles are the ones that I'm talking about. And once these develop, they are permanent. Okay. Now, some patients may ask me, why do some smokers get COPD while others don't? My friend smoked too. How come he doesn't get COPD? So let me share with you a diagram of how our lungs develop over age. When we are young, our lungs keep growing and they reach the maximum size when we are in our 20s and 30s. Now, some people actually are born with smaller lungs, and that can be because of a few reasons. This can be due to premature birth. This may be due to low birth weight, or they may have developed a lung infection or lung disease in childhood. And this reduces the lung growth during their young adulthood. So some people are born with smaller lungs at their peak, all right? And this results in them developing COPD in a more, susceptible manner. All right, this graph shows you the lung function decline, even if you're not a smoker. So if you are not a smoker, all our lungs actually decline with age from 30 years onwards. And you can see in this graph, the green line and the dark blue line represent the normal rate of decline in an adult, right? So if you have a small lung when you're born, all right, and your lungs don't develop fully, all right, even if your lungs age and decline at a normal rate, you are still more prone to getting COPD, if you're exposed to even just a little bit of cigarette smoke or air pollution. Now, if someone has normal lungs and they have their peak, lung function at 30 years old and they smoke very heavily, this rate of decline accelerates. And this rate of decline will result in them developing COPD in their later years. Now, who are more prone to getting COPD? Female gender is a risk factor. We know that female patients develop COPD even if they smoke fewer cigarettes than their male counterparts, or if they start earlier. Right? Persons with lower peak lung function, for example, premature birth, low birth weight, and childhood lung disease. Okay. Now, do you know that because of the amazing function of our lungs, globally, up to 80% of people with COPD are not diagnosed? Many people attribute the symptoms to aging. All right. Many of us feel that it is normal to feel short of breath, when we're aging. People who smoke often have some cough and phlegm every day. And when this cough and phlegm becomes a bit more persistent, it is not uncommon that our patients feel that, oh, this is just part of the smoker's cough. Many people also with COPD also develop what we call frequent colds or bronchitis, and they often seek treatment with their family doctor or general practitioner, before they actually see a specialist in hospital for diagnosis. All right. So sometimes these symptoms, if you have them, it is good to get tested early so that we can diagnose you and start you on treatment. Okay, so who should get tested for COPD? Now, patients who develop COPD are typically 40 years old and older. All right. And, if you have a history of tobacco smoking, all right, For example, if you smoke 1 pack a day for more than 10 years, that will be considered significant. Or if, for example, you are chronically exposed to lung irritants, for example, maybe, in the past, maybe when you were younger, and when Singapore was less well developed, we cook our food with wood fires, all right, for a prolonged period of time. That may also be a risk factor. Of course, now when we have, natural gas for our cooking stove, electric stove, this is much less prevalent. Okay, so if you have the risk factors, plus you have any of these symptoms, chronic cough, chronic sputum or phlegm production, chronic shortness of breath, chronic wheezing, all right, frequent wheezing, frequent colds or respiratory tract infections like bronchitis, then do consider getting tested. And the test we need to do is called spirometry. This is a picture or diagram showing what spirometry looks like. All right. Now, how does spirometry help us diagnose COPD? Well, spirometry measures the narrowing of the airways in the lung. So, for example, on the right here, you can see a normal lung on the left, and this is someone with 100% lung function. And someone with COPD will have narrowing of the windpipe to maybe about 50%. And spirometry can actually pick up this abnormality and help us diagnose a patient with COPD. Okay, so let me play a video of a young patient who's undergoing a spirometry test. All right.
Go. Go harder, longer. Go. Tahan. Suck in. Okay.
Okay, so this is how the test is done. It's very fast, can be done in less than a minute. And what it does is it measures airflow from our lungs, all right, over time. So to do this test, you need to actually take a deep breath and breathe out very, very hard as if you were blowing birthday candles, all right? And breathe in and breathe out until your doctor or nurse tells you to stop, all right? Now, this test is non-invasive. There's no injection, there's no blood taking, there's no pain, but you have to put in your effort when you do the blowing test, all right? And this can be done in your polyclinic or general practitioner office with a very simple device. So if you have if you're 40 years old and you smoke cigarettes in the past, or even if you quit smoking in the past and you smoke for many years, and you have any of those symptoms, do ask your doctor for COPD screening with a spirometry test. All right. Now, when we do the spirometry test, we also sometimes do a part 2 of the test. All right. We call it a bronchodilator, or what we call inhaler test. Now, if we find that your spirometry result shows that your lung windpipe is very narrow, sometimes the doctor will order a second test where we will give you an inhaler and we will repeat the test again. Okay, what does the inhaler do? All right, so this is a patient getting an inhaler. Okay, he's given an inhaler through a space chamber. And what it does is it brings medication to open up the airways in the lung. All right, and what happens is we will repeat the spirometry test again about 15 to 20 minutes after this medication is given. Now, if you have COPD, this will result in the airway opening it up and it will show improvement. And this helps us determine how severe the COPD is. Okay, now COPD can be diagnosed much earlier with a spirometry test. And this is a diagram to show, symptoms over age. All right, so most patients with COPD, unfortunately, only develop symptoms at the very end stage. And many of our patients who have COPD are diagnosed well into their 60s and 70s. Right, by the time you actually have symptoms, this means that your COPD is very advanced. Okay, now if you have spirometry, you can diagnose it in a much earlier fashion. All right, and we can diagnose it in the 40s and 50s even. Now, is it possible to diagnose COPD with X-ray? It is possible, yes, but this will also again be only diagnosed. We can only diagnose it at a much later stage. So we recommend that spirometry test is the test of choice when we want to diagnose COPD. Okay. CT scan can also help us diagnosing COPD, and as shown, when we do a CT scan, we can look for the changes of COPD from smoking and air pollution on the lung. And we can see these little air bubbles here that I described earlier, and we call this emphysema. If you have emphysema changes, this means that you have a lot of exposure to lung irritants like cigarette smoking or air pollution, and most likely you have advanced COPD. Okay, now what are some of the treatments? Now, this is just an overview. Later, my colleague, Dr. Tiu Pei Yi, as well as Sister Alicia, will be sharing with you the effective treatment of COPD, all right? And we also have Nurul to share with us exercise therapy, which is a cornerstone of COPD treatment. After me, Dr. Candy will share with us the most important part of the treatment, which is to quit smoking, all right? This is very important, all right? And of course, inhaler therapies, there are many. We will share with you our experience and what is the preferred inhaler. Medications like mucolytics, medicines to dissolve phlegm. This helps patients with chronic phlegm production clear their sputum so that they breathe more easily. Okay, exercise therapy is very important. Even if you're short of breath, it doesn't mean you shouldn't exercise. In fact, that's a reason for you to exercise even more. Vaccinations are important. Vaccinations of flu, pneumococcal infection of the lung, as well as COVID infection are recommended. And importantly, eating healthily and breathing healthily. Okay, so this is my last slide. Some take-home messages for everyone today. Many patients with COPD in Singapore and around the world are symptomatic but undiagnosed. All right, and that's often because our lungs have tremendous spare capacity, and significant symptoms will only appear when a lot of lung function is lost. So what can we do about it? We can do a test called spirometry if we have the right risk factors. If you have a history of smoking, 40 years and above, and symptoms, we can diagnose COPD and start treatment earlier with this test called spirometry. So if you have smoke, you have symptoms, go see a doctor to get a test called spirometry to get tested for COPD. Thank you, everyone. We'll take questions later on in the webinar. Thank you.
Thank you very much, Dr. Chu. Hi. So just a gentle reminder, there's a Q&A chat box, so do key in your questions in the chat box. So next, I would like to introduce Dr. Ken Lee. He's a consultant of Department of Respiratory and Critical Care Singapore General Hospital. So he will talk to us about I have tried to quit smoking but was unsuccessful. What kind of help is available? Dr. Ken Lee, please go ahead.
Thanks, Karen. Yep. So you can see the title is quite a mouthful. Yeah. So a very good morning to our audience, and again, welcome to our COPD webinar. So if you look at this title here, it says, I've tried to quit smoking, but was unsuccessful. What kind of help is available? This is essentially a call from many of our smokers for help. Okay. And for today's presentation, I do hope to share with you some helpful information, both for smokers among our audience, as well as for the non-smokers who might know some of your close ones who smoke. Hopefully this information will come across as being helpful to you. So I think that many of us view smoking as a personal choice, a lifestyle option. And one of the problems is that we don't realize that even if the smokers had made the initial choice to pick up smoking, we often do not realize that once they get nicotine dependence, some of them wish to quit smoking, they have the will to quit, but the body doesn't allow them to. So I think yeah. So I think it is important for us to understand how the smokers feel, and actually from then on able to realize some of the problems they face and identify which are the areas that we're able to help them with. So I think to start off, I think we want to see what's the perspective of a smoker, and this is some data that we have gathered from a recent survey that's conducted by the Singapore Cancer Society, looking at the various reasons why smokers picked up smoking. So you can see here, parental smoking is a major factor. 58% of the youth smokers reported having at least one smoking parent, compared to 27% among the non-smokers. 90% of our young smokers have at least one close friend who's a smoker. And the media has a huge influence on our youth. If they may view smoking as something that's desirable, especially when their favorite celebrities are smokers. Teens are curious. They love to experiment. So they may try smoking thinking that it's something that's really cool. And there's the misinformation for a lot of our young smokers as well. Number one, smokers they tend to downplay the health effect of smoking. And the youth themselves, they underestimate the addictive nature of smoking. They think that, even if they picked it up, they can quit smoking anytime. So earlier I mentioned that, in our society, a lot of us view smoking as a personal choice. But if you look at the reasons that are listed here, why people initiate smoking, you realize that actually this personal choice is largely influenced by a lot of factors, which means that if someone grows up in an environment where the parents smoke, his close friends are smoking, and he's exposed to media that says that smoking is something cool, it is really not surprising that he picks up smoking. So put it simply, if we were born in a world where 90% of the people around us are smoking, there's a high likelihood that we may grow up to be smokers. So that's something that we should bear in mind. So from the same survey, let's look at again, some of the perspectives of smoking from the smoker's point of view. 70% of them actually feel the relief of stress, tension when they smoke. It helps them relieve their nervousness, fear, or anxiety in, again, about 70% of the patients. About 60% of them feel happy, relaxed when they smoke, and 70% of them say they smoke in social situations simply because their peers around them smoke. So again, one of the things that we don't realize that, on the one hand, the smokers, we want the smokers to quit smoking because we know that it is something that's helpful for their health, for their good health. But we don't realize that when these smokers stop smoking, we actually remove some of these benefits, so-called benefits that the smokers are experiencing when they pick up the cigarette. So the smoker will say, I use my cigarette to help me relieve stress. I feel less nervous. I feel happier. So when we get the smoker to stop smoking, the stress increases, the nervousness increases, the smokers may become less functional. So we need to bear that in mind again, and that will help us to address some of these issues, because once we are able to identify these issues that the smokers may have, then we are able to understand how we can help them so that they don't have to use smoking as a means to help them solve some of these problems. Okay, so these health effects of smoking is something that a lot of us are very familiar with. And I just wanted to highlight some of the interesting facts and figures about smoking itself. Number one, smoking-related chronic diseases like COPD, heart problems really develop only after a few decades of smoking. So if you pick up smoking, last week or over the past 1-2 months, you may not actually realize that it has an impact on your health because you only see it very much later in life. The lung cancer risk is 25 times higher among the smokers compared to non-smokers. Okay, lung cancer risks, even for light smokers, are substantial compared to non-smokers. So you don't have to be a heavy smoker to have an increased risk of lung cancer. Okay, the coronary heart disease and stroke risks are 2 to 4 times higher among smokers compared to non-smokers. And if you quit before 40 years old, it can reduce the risk of death from all these smoking-related diseases by about 90%. Okay, what about the effects of smoking on survival? So this data here is from one of the major medical journals, okay, and we can see here that in all 4 graphs, obviously it's shown that the earlier you quit smoking, the better. In fact, if you look at the top left graph, you can see that for smokers who stop at the age of 25 to 34 years old, they can live almost as long as someone who's never smoked before. And the other thing you also realize from this diagram here is that, it's never too late to stop smoking. Even at the age of 60, when you stop between 55 to 64 years old, you still gain that extra few years of life compared to, if you continue smoking. So it's never too late to quit smoking, and it's best to quit it as early as possible. And then there's a whole list of other, diseases that's associated with smoking. The ones we are most commonly aware of would be cancers, heart problems, lung problems. But smoking itself has an impact on many other problems. So patients have diabetes who smoke, diabetes becomes harder to control. It can affect the sexual function, causing erectile dysfunction in males. It can, cause issues with pregnancy or effects on the reproductive system for women. So there's plenty of negative effects that you can get from smoking other than the ones that we are more commonly aware of. So I think the good thing is that once the smoker is worried about the effects on his health, I think that is a good start. Okay, we know that 3 in 5 current smokers are concerned with their health, the effects of smoking on their health. And if you look at this National Population Health Survey that was done in 2019, you find that about 50% of daily smokers, they have plans to quit smoking, okay? Even though only 1 in 5 of them plan to quit smoking over the next 1 year. And then there's about 30%, 20% who did not plan to quit smoking, did not plan to reduce number of cigarettes, but about 30%, even though they did not plan to quit smoking altogether, there's plans to cut down the number of cigarettes that they smoke. Which means that if you look at this pie chart itself, about 80% of smokers, they want to do something to improve their health. 50% want to quit completely, another 30% or so hope to at least reduce the number of cigarettes they smoke. So there's actually a significant number of smokers that we are able to help and at least inform these smokers where they can get help from. And again, the other important thing to note is that on average, smokers try to quit smoking at least 4 times. So this basically highlights that smoking is something that's very difficult problem to solve. even if they have tried to quit smoking once, twice, 3 times, for many smokers, it takes multiple times before they finally successfully quit the smoking habit. Okay, so don't give up. Okay, so this slide here shows the different stages that a person goes through when he tries to change behavior. So in this case, we're talking about the smoking behavior. You have a proportion of patients who might be in a pre-contemplation stage, meaning that they have not even considered quitting smoking at all. And we really want to target these smokers. If they are our close ones, we want to get them to start thinking about quitting the habit. Okay, you have those in the contemplation stage who hope to quit smoking sometime over the next 6 months. Those who are already preparing to quit smoking, maybe over the next 1 month or so. Some smokers have already taken action, and then there are others who successfully quit smoking, and they're trying to maintain or at least prevent a relapse of their smoking habit. So once you recognize that smoking is something that you want to quit, or you want to help someone quit smoking, I think the important thing is to seek professional help. Okay, why is that? Because the literature is clear that for smokers who try to quit smoking on their own, the success rate is really low. Only 3 to 5% of the smokers successfully quit at 12 months. Okay, and why is that? Because a lot of them, they experience withdrawal symptoms. Okay, when they quit smoking, their body have cravings and they suffer the withdrawal symptoms, and that itself prompt them to take up smoking again to try to relieve themselves of these symptoms. And the withdrawal symptoms typically peak within the first few days. Okay, if you're able to overcome after the first 1 to 2 weeks, then I think your chance of staying off the cigarette is a lot higher. Okay, most relapses occur within the first 8 days of quitting, we mentioned. Okay, the relapse rate is about 10% in 1 year, 2 to 4% after 2 years. So if you're able to hold off the cigarette for a longer period of time, your chance of maintaining the status is going to be much higher. Okay, so when you seek professional help, okay, the professional counselors will give you some tips on smoking, and at the same time, they can decide whether or not you will benefit from some medication that can help you to cope with the withdrawal symptoms that your body is experiencing. Okay, so these are some of the quit methods for smoking. You can some smokers they choose to gradually cut down the number of cigarettes they're smoking. Some choose to go cold turkey. So basically, they just stop entirely and hope that their body is able to tolerate all the symptoms until they eventually go past that withdrawal stage. The last two, nicotine replacement therapy, is something that I really like because I think it's really useful for our patients. And professional help from smoking cessation counselors is again very important. Okay, the ideal situation or the best means to successfully quit smoking is really a combination of medication. In this case, we're talking about nicotine replacement therapy along with counseling. And why do I say that? Meaning that if, let's say, you have the will to quit smoking, and you decide that you want to purchase some nicotine replacement on your own, that's possible. You can actually purchase it over the counter. Even then, the success rate based on studies have been shown to be generally less than 10%. Whereas if you combine this medication along with professional help, you can actually increase your quit rate by at least 6 times. Okay, so significantly higher chance of you quitting. Why? Because number one, the professionals are able to gauge your level of nicotine dependence. They know what kind of dosing to give it to you, how to match your dependence, your withdrawal symptoms, and then according to the medication that you require. Okay, so smoking addiction actually has a few components to it. There's a physiological dependence, meaning that your body has developed certain effects from the smoking, will develop withdrawal symptoms when you stop smoking. There's cravings, your body derives pleasure from the smoking itself. There's behavioral dependence, which means it becomes a habit. Every time you sit down in front of TV, drink a cup of coffee, you decide that, I have to take a smoke. So some of these are really habits that you don't even realize it. And of course, there's a psychological dependence. We mentioned earlier how smokers sometimes use smoking as a means to cope with their stress or to suit themselves to the social situation around them. And then there are other environmental factors which might be helpful to improve the success of quitting smoking. So in this cross-sectional survey, you can see that 66% of smokers, if they find that if they get help to quit, they're more likely to succeed. A conducive environment definitely helps. So if you are, in an environment where you have your friends and your relatives who are very supportive of you quitting smoking, then that is very helpful. So yeah, family members' encouragement is very important. So these are some tips for smoking cessation. Okay, the 4 Ds, easy to remember. Number one, delay. Okay, if you're a smoker, you wake up in the morning, you suddenly have this decision, I want to quit, I want to smoke my first cigarette now, you just wait for a few minutes until the urge goes away. Okay, breathe deeply, deep breathing, take a 5-minute breathing break. We breathe slowly and deeply, that helps as well. Sometimes you want to distract yourself, go talk to a friend, and hopefully a non-smoker, obviously. Okay, so get up, walk around, distract yourself with some other activities, and maybe drink some water, sip the water slowly, hold it in your mouth. These are some of the simple things they can do at home, okay, to try to help yourself quit smoking. Okay, we mentioned about nicotine replacement therapy. So there are different kinds of nicotine replacement. It can come in the form of patches, gum, lozenges as well. If you're 18 years old, you can actually purchase it over the counter. Okay, but if you are below that age, then you'll need a prescription from a doctor. There are other medications as well, certain medications like varenicline, bupropion, which can be prescribed by the physician. Okay, so all these will be decided by the physician, if they think that these are helpful for you. So for nicotine replacement itself, I mentioned earlier, it's best to combine it with professional counseling, professional help. Some other things to take note of is, number one, the dosing need to be correct. A lot of times, smokers, they get some nicotine replacement, but because the dose of the nicotine replacement is quite low, it's not enough to help them overcome the effects of their withdrawal symptoms. It has to be given for sufficient duration. So generally speaking, nicotine replacement is prescribed for a duration of at least 3 months. Some patients, you can drag it longer to up to 6 months or even a bit longer is possible for you to stay off the smoking habit. The technique is important, particularly if you are using things like nicotine gum. You need to know how to use it properly. And even for things like a nicotine patch, there'll be certain advice that the pharmacist may tell you, for instance, using a patch on different arms every day instead of using over the same site. And combination NRT is important, meaning that a lot of times when we prescribe nicotine replacement, it's usually a combination of both the patch and either the gum or the lozenges, not on its own, because that actually improves the success rate of quitting smoking. Okay, so I think for the last couple of minutes, I'm going to talk a little bit about electronic cigarettes, because I think it's something which is of interest to a lot of people in the public. They want to find out a little bit more. So firstly, the e-cigarette market size has really increased significantly over the past few years in Southeast Asia, in many countries. Okay, even in Singapore, look at the number of vape cases that's handled by HSA is increased dramatically. Okay, even though we've established that vaping is banned in Singapore. Okay, so e-cigarettes or vaping, the vaping or the use of e-cigarettes is actually marketed as a harm reduction strategy. So basically, the idea is that smokers use the e-cigarettes and hopefully use that as a means to cut down the number of conventional cigarettes that are smoking currently. That's the so-called potential benefits that's being proposed by these companies that produce the e-cigarettes. Unfortunately, there's a lot of harms associated with e-cigarettes. Okay, so the immediate harms is, number one, there's been multiple reports of device malfunction. So some of these devices, they actually explode, okay, causing injury to patients. E-cigarettes, vaping itself has been associated with lung injury. So I work as a respiratory physician. I see cases of patients who take e-cigarettes and they suffer lung injury that's so severe that they have to go to the ICU. This is something which doesn't come across as serious to a lot of patients because they don't see it in the hospital. Okay, they just hear the benefits from the advertisements of these e-cigarettes, but they don't realize that there's a significant number of people who have tried it and who have suffered the consequences of that. And long-term harms is also something which is which we are very worried about. Okay, number one, if you look at the studies on patients who tried to use e-cigarettes as a means to quit smoking, yes, some of them, they managed to cut down the number of cigarettes that they smoke, but the problem is they continue to use the e-cigarettes for the long term. So essentially, you're replacing one harm with a different harm. Okay, because the e-cigarettes, how it helps is that it contains nicotine to try to replace the nicotine component that you obtain from the conventional cigarettes. But they don't actually try to reduce the level of nicotine dependence. So which means that the essential problem of nicotine dependence is still present. And these smokers who continue to use e-cigarettes continue to take in the nicotine, addicted to nicotine. And at the same time, there's a lot of ingredients in the e-cigarettes which continue to cause harm to the patients. Okay, so in the long term, there's going to be risk on the respiratory health of the patient, the heart condition of the patient, and the cancer risk of the patient as well. A lot of these ingredients can cause cancer risk in the long term. Same thing for cigarettes. If you smoke today, you're not going to get cancer tomorrow. Okay, it takes many years later when some of these problems develop. The same thing for e-cigarettes. All right. So these are just some of the reports that we see of how e-cigarette devices, can malfunction, leading to explosion, causing problems in the patients. All right. So in fact, if you look at the number of ED visits in countries that allow for e-cigarettes, for instance, in the US, you can see there's a huge increase in the number of ED visits. And all these ED visits, the ones that are shown here, are really for lung injury or for conditions that's related to the use of e-cigarettes. And we really don't want that to happen here. Okay, so in summary, there's not enough scientific evidence to support e-cigarettes as an aid to smoking cessation. It poses harm. Okay, there's a high risk of sustained nicotine addiction, and the long-term effects of e-cigarettes are not established because it's still fairly new and you're going to see the effects of e-cigarettes only many decades later. All right, so I want to say once again, that it's not too late, never too early to quit smoking. You should really do it right now, right away, right now. Okay, and these are the smoking cessation services in Singapore. Okay, you can approach the polyclinics, retail pharmacies. They have pharmacists who provide some professional help. The Health Promotion Board has an I Quit program. You can search it up. And also in hospitals, we also provide a smoking cessation service for patients. All right, thank you very much.
Thank you, Dr. Ken Lee. So to remember, it's never too late to quit smoking. So now we'll take a short 5 minutes break. So we'll come back in 5 minutes time and we'll continue with 2 other exciting talks lined up for you. Welcome back. Thank you for continuing to join us on our webinar. Next, I would like to introduce two speakers, Dr. Chiu Pei, consultant of Department of Respiratory Critical Care Medicine, Singapore General Hospital, and Sister Alicia Lee. She's a nurse clinician, also a patient navigator that helps with COPD management. They will be talking about what kind of treatment is available for COPD. Please go ahead, Dr. Chiu.
Good morning. So I will share about what kind of treatment is available of COPD. So this is my outline. So I will first touch on the burden of COPD, the goal of treatment, and what are the treatment available, and what is COPD flare. So the burden of COPD in Singapore is estimated to be around 2 to 6%, and it's an important disease that is coded as a 9th leading cause of disability life year loss. And in Singapore in 2019, COPD is the 10th leading cause of death. And while we know that smoking is the main risk factor for COPD in Singapore, it was found that 30% of COPD patients are actually non-smoker. And so why is it important to treat COPD? As we heard from the first speaker, patients with COPD can actually present with cough, breathlessness, sometimes they may have wheezing or chest tightness, and sputum production or phlegm productions. So the treatment of COPD is aimed to reduce such symptoms. And importantly, we also aim to reduce the risk of poor outcome, such as death associated with COPD, progression of the disease, and also COPD flare. So what exactly are the treatment of COPD? So I categorize them into two main groups. First, we call it non-pharmacotherapy, which does not involve medications. And second will be pharmacotherapy, which involves different type of medications, mainly the inhaler. So we will go through each category of the treatment. So for non-pharmacotherapy, it is important first to understand what is COPD. So we need to educate patients what is COPD, how can they manage the COPD themselves, and what to look out for, and how to avoid the trigger. And as Ken have mentioned, smoking cessation is very important and it's never too late to stop smoking. And vaccination, such as a yearly flu vaccine and also pneumonia vaccine, can actually prevent patients from getting a flu or lung infections. Pulmonary rehab program and also exercise program is also important. So pulmonary rehab is actually available in most hospitals. It's a comprehensive program that includes exercise program, educations, and also to teach a patient how to self-manage. And lastly, also nutritional support is also important, particularly for patients who are underweight. So they need some nutrition support to increase their muscle strength, which can actually help with the symptoms and also quality of life. So this graph has been shown previously. So on the horizontal axis is the age, and on the vertical axis will be the lung functions. So as Dr. Chiu, our first speaker, have mentioned, different people may have a different lung function achievement, and most people may achieve their lung function 100%, up to 100% by the age of 20 to 30. But some people may actually have lower lung functions due to previous insults, such as recurrent infections or childhood infections. But irregardless, usually our lung function will decline by the age of 35 in a slow rate. But in susceptible individuals who smoke, the lung function can decline very rapidly, leading to the development of COPD. Why we keep saying that it's never too late to stop smoking? So if you stop smoking, even though you have a really developed COPD, your lung function decline can actually slow down to what it is like for a normal individual of your age. So this will prevent excessive loss of lung function. So next, we go on to the treatment, medication treatment for COPD, which we divided into controller and reliever. So controller treatment is the mainstay of treatment for COPD. So it is used daily to keep the COPD under control. It consists of broadly the long-acting bronchodilator, which help to open up the airway, or we call it bronchodilator, and inhaled corticosteroid, which actually reduce the inflammation. So it depends on the condition of the patients, then the doctor will decide which type of inhaler, whether it's a mono, dual, or combination therapy. So this will keep the airway open and also reduce airway inflammation. And some of the side effects for inhaled corticosteroid particularly is that sore throat, hoarseness of voice, and sometimes mild infection. So therefore, we usually ask the patient to gargle after using the inhaler which contain corticosteroid. There's also treatment, which is mucolytic. It's medications that actually help to loosen the phlegm or sputum, especially for patients who have a lot of phlegm. So the next group will be reliever. So reliever provide quick relief of COPD symptoms. And this inhaler relieves symptoms by opening the narrow airway rapidly. So they are only used when needed, such as during an COPD flare or attack. And we always advise patients to actually carry the reliever with them and use them as instructed. So there's so many different types of inhaler device. How do we decide which inhaler device to prescribe for each patient? So this actually is individually tailored, and we will look at several factors to decide on the type of inhaler that is suitable for the patients. So this includes the patient's factor. So patients itself is the most important one. They have to accept the inhaler and they are willing to try the inhaler and the ability to use it, the device itself, and also the formulation. So patient's factors such as the age, the ability to use the device, the conditions of the disease, what type of treatment they require, and they also have to accept, and also we have to take into consideration their preference of the device. Next would be the device itself. The cost, of course, is important, easy to use, and it needs to be portability, easy to carry around, and also available in the institutions that prescribe it. And also we look at the efficiency of the device to the site of action. And formulations have to be safety, stable, and also the dose. Some inhaler is once a day, some is twice a day, some is 1 puff, some is 2 puff. So dose is also a factor for certain people. Some may prefer once a day, some may prefer twice a day dosing. So there is broadly 3 main type of device as shown here. So the meter dose device, which is the most frequently used as is available in most inhaled medications and also in the reliever. But the disadvantage of this device is that it's not breath actuated, means that they need some coordinations with the patients. They also have high oral deposition, means rather than going into the airway, it may stay within the mouth if the inhaler technique is not good. The second group will be the dry powder inhaler. So this device actually is breath actuated, means that the device will activate it when the patients inhale into the device. There's also a dose indicator to tell you how many or how much the medicine left inside. But the disadvantage of this inhaler is that it requires some inhalation effort. So you need to inhale in sufficient effort before the medicine can actually deliver. And it's also moisture sensitive as it's a dry powder form. And lastly, there's also a soft mist inhaler, which actually depends, it doesn't depends on the inhalation rate. So it has a high lung deposition. There's also dose indicator to tell you how many or how much inhaler left. It's not breath actuated like the meter dose device, so it requires some form of coordinations. And meter dose, the soft mist inhaler also requires some strength and dexterity to prepare the inhaler. So some patients may find it difficult to actually load the inhaler. So apart from the pharmaco and non-pharmaco treatment that I mentioned just now, there's also other advanced treatment for certain COPD patients. So long-term oxygen therapy may be required for patients who are at advanced disease. And generally, we actually ask for more than 16 hours a day of oxygen use if they require it. There's also some patients that require ventilatory support, especially when they sleep at night, to help them to get rid of the carbon dioxide. So there's also bronchoscopy treatment. This is a more advanced treatment in selected patients. It's not a cure for COPD, but it treats selected symptoms such as breathlessness. And there's also surgery, such as lung transplant for patients who are at younger age group, generally less than 65 years old. And of course, supportive care to treat the symptoms based on the patient's disease conditions. So next, I will touch a bit about what is called COPD exacerbation or flare of COPD. So COPD exacerbations or flare is a sudden worsening of the baseline symptoms, and usually is caused by bacteria or viruses infection, and sometimes also by air pollutions. It is important to treat COPD exacerbation as it leads to a higher death rate or mortality. It can actually cause a disease progressions and also decrease the quality of life. So how do we treat COPD exacerbations? So first, with the inhaler, so it's with reliever. Generally, we give it with a spacer. We also prescribe steroids, either through the oral or intravenously, depends on the conditions of the patients. And some patients may also require antibiotics during the exacerbation. And also oxygen therapy, and in severe case, they may require ventilatory support as well. So how do we prevent COPD attack or exacerbation? First, the most important is smoking cessation, because smoking can also lead to COPD exacerbation. Yearly vaccinations for flu and also pneumonia vaccination. Then adhere to the treatment that was prescribed, such as the maintenance inhaler. And also pulmonary rehabilitations, which I mentioned is a comprehensive exercise program and also education and self-management. So in conclusion, COPD is a chronic disease. It's never too late to quit smoking, and smoking cessation is an important part of COPD treatment. And daily preventative treatment improves symptoms and decrease COPD flare. And regular follow-up is required for patients with COPD. So I'll move on to let Sister Alicia Lee to talk about the nurse navigator role and also some of the myths of COPD. Alicia, please.
Hi, good morning, everyone. Welcome to this webinar. Thank you for joining us. So basically, my role is to teach the patient who are newly diagnosed with COPD, let them know what is COPD about, how is it acquired due to their lifestyle, what they can do to help them to relieve their symptoms, such as their lifestyle, modify their diet, and of course, share with them the importance of smoking cessation, which is important, which is the ultimate goal that we want to achieve as a patient, as a nurse, to help them to control and stabilize their COPD in the community and at home. Besides giving them counseling on what is COPD, I also teach them on the inhaler technique, which Dr. Tew has mentioned. So as a patient pertaining to inhaler itself, it's important that they know how to coordinate the inhalers on a daily basis, how to inhale, how to press, after assessing whether they are able to cope and coordinate the inhalers well. Sometimes during assessment, it is noted that actually this particular inhaler doesn't suit their lifestyle. So I will get the doctor in charge to try to, we will discuss and see which types of inhaler works well for each different kinds of patient. And at a subsequent clinic visit, we will review the patient's technique again and see how they coping well with that particular inhalers. So as a nurse, besides giving them counseling on what is COPD about and teaching them the right way to coordinate the inhalers, I also liaise with my counterpart nurses at the committee, so that patients who are like loners, who stay alone, I will get them to conduct home visit or do a health and home assessment and continue to revise the inhalers with the patient from their home, which is supported by community nurses, which covered under the Sync Health clusters. Yeah, so besides getting my community nurse to follow up with them from home, I also liaise with the social worker to give them financial support, and also patients who feel that they will benefit from the pulmonary rehab. I also get them to be referred by our inpatient physiotherapists and occupational therapists, so that with the exercise on board, the patients, their care is much holistic and much more well coordinated from the home and from the house perspective. Yeah. So to manage COPD as an overall health outcome, it's not just a doctor's perspective itself. It's definitely a multidisciplinary team. So everybody plays our part, and we work together to achieve the best outcome for our COPD patients. So it's definitely an interprofessional educations among all the allied health. Yeah. So facilitating patients with the community and to transit them from hospital to home is also part of my job. Yeah. So after removing them from the clinic and from the ward setting, I will conduct telephone calls to check on them. Have they managed to reduce their cigarettes? So I will continue to encourage them, to inform them that smoking cessation is important to prevent the disease progression of the COPD. And then also check with them, have they received their next follow-up appointment? If they have not received, I will let them know when is the date and what time and where's the location of the COPD consultation, so that they are aware and they are able to come for the follow-up appointment. Yeah, so the aftercare from the hospital setting is important so that we ensure that the compliance of the appointments and the healers is crucial to the long-term care of the patient. Yeah. Okay, now I shall touch on the COPD myths and facts. A lot of patients have the mentality that once that I'm stable, I will not to use the inhalers forever, and they often have the mindset that smoking lesser is actually, and they also have a perception that I can't quit smoking. If I quit smoking, I will die very fast. But it's important that as a nurse, as a counselor, I let them know that smoking is the main cause of COPD. Yeah, so to let everyone know that the fact that 10 to 20% of people who got COPD have never smoked, which is actually wrong. Exposure to fumes, chemicals, dust, or harmful pollutants can also result in COPD developing too. It's just not smoking, but also, so I have a lot of patients who also never smoke, but they also develop COPD in the long run due to their previous occupation. So most of my patients, the background, they are like metal welders, carpenters, some of them are construction workers and renovation contractors. So the prolonged years of exposure to these dust and chemicals can also develop COPD. So the next line is COPD is a rare disease. So basically for everyone information, COPD is actually the third leading cause of death in the US. And in Singapore itself, it is a 10th leading cause of death. Yeah. So the third line, I haven't got COPD. This is just a smoker's cough. So for everyone information, there's no such thing as a smoker's cough. If you're experiencing a recurrent and productive cough, and have lots of sputum production every morning, such as upon waking up, most likely you could have a inflammation airway, which can be a sign of bronchitis, which is one of the main cause of COPD. So do consult a doctor if you have this persistent cough for months and for years. The next point, I smoke for more than 20 years. Stopping now wouldn't make any difference. So as what Dr. Kenley has mentioned, it's never too late to quit smoking. If you stop smoking, can I have the slide, please? Thank you. So if you do stop smoking, there's always lots of benefits to control and to sustain the COPD and to stabilize it. Yeah. So firstly, if you quit smoking, it will dramatically reduce your risk for heart attack. Naturally, if you quit smoking, life expectancy will be prolonged too, adding more years to your life. Hence, the ultimate goal is never too late to stop smoking. Some of my patients also mentioned that now that I'm so chuan, I cannot exercise. It will make me more chuan. So to let everyone know, exercise is always part of the treatment package. whether you have COPD, diabetes, or heart failure. Exercise has been proven that it is safe and definitely beneficial. You can always speak to us, the doctors, or our physiotherapists to see what are there are types of exercise which is suitable to help with your breathing, such as pursed breathing, which will make you feel more calm. And there are types of exercise you can stretch and strengthen your lung muscle, which will definitely help to control your COPD. Next, COPD only happens to older people, which is not true. So with the advancement of spirometry and other types of investigation, COPD can be diagnosed early. So we have seen in our experience, COPD is getting younger. So most of them can be diagnosed as early as in their 40s. Yeah. So it's always get all this investigation done to detect the condition early so that the treatments can come in early to help you. Yep. Okay.
So thank you.
Thank you, everyone.
Thank you very much, Dr. Tew and Sister Alicia. So you guys will know what is the myth and facts about COPD and what kind of treatment we have. So the whole morning we have gone through what is COPD, how to quit smoking, and what kind of treatment. Last but not least, we'll like to welcome Miss Nurul. She's our senior physiotherapist in Department of Physiotherapy, Singapore General Hospital. So she will answer this question that many patients will ask. I've been diagnosed with COPD. Is it safe for me to exercise? Nurul, please.
Thank you so much. Let me share my slide.
Yep, we see it clearly. Thank
All
you.
right. All right. Good morning, everyone. Thank you for still staying on for the last topic on exercise. So my name is Nurul, and I'll be talking about exercise in general. Okay. Okay. So we're gonna talk about what is exercise. Okay. Why we need to exercise, when we need to exercise, who should exercise with COPD, how then we exercise, and where can we exercise. Okay, so what is exercise in COPD? Okay, so exercise is actually part of a comprehensive intervention based on intervention of pulmonary rehab, where patient undergoes a thorough assessment and the therapies are targeted to patient. So we exercise as part of the therapy package with the general aim to improve the physical function and emotional function of the patient. Okay, so in this diagram of this gear wheel, so exercise training is part of the program component. Okay, so why we need to exercise when I keep coughing all the time, when I'm so breathless already, I have no energy to exercise, I'm so weak, I have no strength. So this is the reason why. Okay, due to the impact of COPD on the lungs, we get breathless easily with exertion. We will then avoid activities that brings about breathlessness, such as exercise. Then we don't exercise. Then we get deconditioned with the ongoing damage to our lungs due to COPD. We'll then get breathless easily with simple activities, and we'll then further avoid more activities, resulting to further weaken of your lungs, resulting in this vicious cycle. Okay. So in addition, factors such as cigarette smoking, use of the steroid, and frequent exhibition, which are the main causes of COPD progression. So these factors are associated with changes to the muscle fibers and reduce the muscle size. And these result in the muscle weakness and reduce in the muscle endurance. So you get reduced in your mobility and you get deconditioned. Okay. Besides changes to the muscle, there are negative changes to the chest wall and your lungs, which further cause a feeling of breathlessness. Okay, so exercise can break this vicious cycle. Okay, so with stronger muscle, you will lead to better exercise capacity. And then when you have stronger muscle, you then take less effort needed for a task. Okay, and then you will feel less breathless when you have to exert. So pulmonary rehab in COPD, which include exercise, has shown that an evidence A, so in stable patient, it has shown that it reduces breathlessness, improve their health status, and improve in your exercise tolerance. Also, there's a high evidence of showing that pulmonary rehab can reduce the level of anxiety and depression in stable patient. Okay, And evidence B, it shows that it reduced the hospitalization rate among patients who had a recent COPD exacerbation. So when should I start to exercise? You may ask, okay? So exercise can be done at any point of your disease trajectory, okay? Who then should exercise? So anyone who experiences any of these symptoms, feeling breathless, feeling tired, having chronic cough, if you have impaired health-related quality of life, if you find that your function is getting worse, your work is being affected because of your COPD symptoms, and you find it hard to do things in your day-to-day activities, such as showering, going to doing household chores, doing your marketing, okay? You find it harder to manage your various medication, your inhalers, your mucolytics, okay? You are getting more anxious, you're getting more depressed, feeling low. You have poor nutrition status, you have poor oral intake, you have no appetite to eat, okay? You find yourself keep going to the doctors for medical treatment because of your symptoms. And if you have a pulse oximeter at home, you find that your oxygen level is low, even at rest or even at activity. So these people should exercise, okay? Then the next question is, who should not exercise with COPD, okay? Technically, there are very few contraindication. The majority of them is those who have uncontrolled cardiac disease, meaning your cardiologists or your cardiothoracic surgeries are still finding ways to optimize your cardiac function. Then you may ask that, I have knee pain, I have back pain, how do I exercise? Or now I'm needing a tongkat or a walking stick to walk, okay? So don't worry, the physiotherapist can modify your exercise accordingly. So the next question you're gonna ask is, how then do I exercise? Okay? So we can look at endurance training, basically to train your stamina. So with every exercise, you need a prescription, okay? So we need to know the frequency, the intensity of the exercise, how long to do it, and how to progress the exercise. So for endurance training, you need to ideally do it 3 to 5 times a week with moderate intensity. So on a scale of 0 to 10, where 0 is you're not feeling breathless, and 10 out of 10 is where you feel extremely hard to breathe, we are aiming between 4 to 6 out of 10, which is the moderate intensity. So 20 to 60 minutes per session is the ideal session to train your endurance. So you can progress it based on your symptoms. If you find it that today I can walk for 10 minutes is not moderate intensity, you feel that you can do more, so you titrate your symptom based on the score, okay? You also, if you find it that I cannot do 10 minutes continuous walking, you can do it at interval training. So you can break it up into 2 sets of 5 minutes of fast walking, okay? So remember to warm up and cool down after your exercise. So looking at the image here, you can do fast walking, you can do cycling as part of endurance. If you can do like stairs climbing or like step aerobic, and like this picture, okay? So that's to train your endurance. Next up, we need to train your muscle or the resistance training. So you can use a dumbbell or you can use weights using your water bottle, a 500 mils of water bottle. You can also use your body weight as part of your training, okay? So here is the recommended exercise prescription for resistance training, okay? Do take note that with resistance training, you should be doing the proper technique to avoid any injury, okay? So avoid Valsalva maneuver, meaning holding your breath as you do it, okay? Ensure that you breathe and move through the entire range of motion of the training. But something you need to consider when you exercise is you need to make sure that your bronchodilators are being optimized, okay? So you need to know where is your rescue reliever inhaler, okay? If you find it hard to coordinate, use a spacer, okay? If you have a heart medicine for your chest pain, okay, your GTN, you need to know where are these medication, okay? You need to know also where is your ideal blood pressure range. And then if you have a pulse oximetry at home, ideally you need to stop exercise if your oxygen level is low, less than 85%, and you can rest and restart your exercise if your oxygen level is more than 90%. Okay, so I always advise the patient, if you need to exercise, make sure you know where's your rescue inhaler. You should bring it along with you. And if you have a cardiac medicine, your GTN spray or in the pill, you have to bring it on you at all time. So the next question is, where do I exercise? Okay, I would like encourage everyone to get their assessment by the medical professional first. So if you are referred to a physiotherapist from your lung doctor, what you can expect on a day of assessment is we're going to do various assessments to check your endurance, okay, your muscle strength. We're going to assess your symptoms and a questionnaire about your quality of life. Then we establish rehab goals that is achievable, a SMART goal, okay, and then from there we can prescribe exercise targeted to you. So in SGH, our pulmonary rehab program has 3 pathways. So first, we have a supervised group-based program in SGH, okay, where patient comes in a group setting. They come at least 1 to 2 times a week, every Wednesday or Friday afternoon, and they will join an exercise program. Secondly, if you're unable to join us, we'll assess you, we'll prescribe exercise, and then it will be an unsupervised home exercise, and then we'll follow up with you month's time to reassess your assessment. Okay. Secondly, we have a virtual rehab program using virtual platform where we do a supervised, it can be a group-based or one-to-one based. Okay, so like I mentioned, in SGH, we have the supervised group-based exercise. It happens every Wednesday and Friday in the afternoon at Sing Health Tower Level 4. Okay, for those who's keen to do a tele rehab session with us, okay, so patients who are suitable includes those who have at least 1 physical assessment done with a physio, okay, you are comfortable using digital platform, or you have a caregiver that is able to assist with all the virtual troubleshooting and setting up. And the important thing is you need to be motivated to exercise. Okay, so this is a short video on how a virtual group exercise is being conducted. My colleague, senior physiotherapist Sophia, in the first 2 video on the left, okay, she's doing a cardiovascular exercise. As you can see, 3 of our patients are joining in their comfort of their home. Okay, so this is how a group exercise can happen. Okay, so let's recap. Okay, we have talked about why we need to exercise. So in summary, if you have stronger muscle, you may feel less breathless. Okay, when can we start to exercise? Anytime in the journey. Okay, who should exercise? So anyone who is symptomatic from COPD can exercise. We went through about how to exercise. I basically looked into more of the endurance and resistance training. Okay, the special consideration when you start to exercise, you need to know where's your rescue inhaler, where's your reliever inhaler. If you are having a cardiac medicine for your chest pain, where's your GTN? Okay, ensure that your blood pressure range are normal, and you should know what's the oxygen level range as well. Okay, and then I went through about the various program that we have in SGH. Okay, so with this title, I have been diagnosed with COPD. So is it safe for me to exercise? The big yes is the answer. Okay, and then that's all for me today. So I hope you can take the question later on.
Thank you very much, Nuru. Thank you very much. So we know that we can exercise as long we are well, no problem. Right, let's invite all our speakers. We'll go through a Q&A session. We got some very exciting questions online. So we can answer on live now.
Thanks, Karen. Maybe I'll take the first question. This is about COPD and asthma. I think there are many questions on this, and indeed, the symptoms of COPD and asthma are very similar. So we have seen many asthmatics who smoke cigarettes, and they will ask, do I have COPD as well? So patients with asthma and history of smoking, please bring this up and ask your doctor whether you have COPD or asthma. In the hospital clinic, what we do is we do lung function tests like spirometry, sometimes even CT scan, and we take a very detailed history about when your asthma started. Typically, asthma, usually starts before the age of 40 years old. all right? And COPD tends to happen after 40 years old, all right? The onset of symptoms, I mean. So sometimes we use a combination of history and we use a combination of tests like CT scans or even lung function tests to distinguish between the two. But the symptoms are very similar. And even the treatments are similar as well. We use inhalers, but of course the inhalers contain different medications and different doses based on the diagnosis of COPD or asthma. So I hope I've addressed the question on COPD and asthma. And a good question about whether, do you have a higher chance of getting COPD? The second question here is number one. Usually COPD, hereditary COPD is very rare. This happens in the Caucasian population where there's this condition called alpha antitrypsin deficiency. So patients who have hereditary COPD tend to have this condition, and usually this happens when they're very young. They are less than 40 years old, and often they have liver disease too. Very rarely seen in Asians. So far, I've not seen any yet. Asthma, however, most of asthmatic patients are actually have an underlying allergic subtype, and sometimes allergies tend to run in the family. So it is possible that if your family members have asthma, it's possible that your other family members may also have a higher chance of developing allergy, and amongst which asthma is one of them. All right. Okay, thank you very much. I guess you can move on to the next question. Yeah, maybe Ken, you can answer this question about smoking.
Okay, so the question here asks whether COPD passed down from generation, even if it doesn't smoke. I think that's been answered by Dr. Chiu. The part about second or third hand smoking and getting COPD. Okay, so maybe just to clarify, I mean, just to let the rest of our audience know what we mean by second hand, third hand smoking. So first hand smoking is where the smoke is directly inhaled by the smoker. Second-hand smoking refers to the exhaled smoke from the burning cigarette that's inhaled by the people around the smoker. And third-hand smoking, we're referring to the substances of the smoke that's left behind on the surfaces of objects around the environment at home. So when it comes to COPD, this condition usually develops after many years of exposure to the substance that causes COPD, and in most cases is smoking. So if you're talking about second-hand, third-hand smoke exposure, for just a couple of minutes, just for a short period, no, you're not going to get COPD. The problem is a lot of times when we talk about second-hand exposure, and in the context of family members, if you're living with someone in the family and exposed to second-hand smoke for many years, yes, there's a high chance you can get COPD over time as well. And similarly for third-hand smoke, and in fact, third-hand smoke is something that potentially might be even more dangerous, particularly if you have, say, small kids, babies at home. Why? Because all these substances that's left on the surface remains there for a long time. So, and in fact, as time goes on, these substances actually turn into something even more toxic. So if your baby's crawling on the floor, touching these substances, breathing in, that is going to cause problems to them. Even if the smoker is outside the house, some of these substances that's left behind the environment, it could potentially be quite harmful. Yeah. So I hope I've addressed this question.
Thank you, Ken. Thank you. Can we have the next question, please?
Okay, so I'll answer this question. So the question is asked about what happened when the inhaler is used too frequently and the side effect of overusing the inhaler. So it depends on what inhaler that you are mentioning here. So commonly the one that tend to be overused are the reliever, which is the blue inhaler, salbutamol, or the ipratropium, which is slightly in green. So if the patients require to use the inhaler very frequent, this is a sign that the COPD is not well controlled. So it could be dangerous if they keep using the reliever without having a maintenance, and they should seek medical attention immediately. And what are the side effects especially for the blue inhaler? If you use it too frequently or overusing it, you can notice that you may have tremor. Your heartbeat can go up, you feel palpitation or chest tightness. And in some cases, it can actually causes some electrolytes imbalance, and you may feel weakness in your legs, limb weakness, and also dry mouth if you overuse the inhaler. So therefore, we do not advise overuse of what was prescribed. And if you have any questions and your symptoms is not well controlled, you should seek medical attention. Yeah, so I hope I answered the questions.
Thank you, Pei. I would also like to just give a shout out to Mr. Carr. Thank you very much for advocating as a member of the public about the importance of quitting smoking. No matter how old you are, what condition you have, it is always good to quit smoking. This actually helps in your medical treatment and also prevents health effects on your heart, your lungs, your brain, so it is always never too late to quit smoking. Okay, can we have the next question, please? Yes, so this is a good question from one of our audience members. Even if you have stopped smoking, even after 40 years, duration, it is important that, if you have symptoms like cough, sputum production, you have shortness of breath, you have chest tightness, do consider going for COPD screening. And this will come in the form of spirometry tests. So even if you have quit smoking some time ago and you have started having symptoms, this might actually be COPD causing your symptoms. It may not be just aging. So I would recommend that if you ever want to consider, health screening, or if you have some symptoms that I described, do consider asking your doctor, that you see, your family doctor, your polyclinic doctor, to refer you for spirometry testing. Okay, I'm glad that that you are considering health promotion. I think it's very important in our elderly and older adults that we consider regular health checkups and optimization to keep our engine running as best as possible. All right, next question, please. Sister, do you think you can help us address this question on how we should use a mask and spacer in the elderly? This is a very important question, and I must say that Sister Alicia and all our nurses in our hospital that see patients with COPD, they are our integral part of our team, and they help make sure that our inhalers are effectively delivered, with the correct technique.
Hi everyone. So we have a spacer here. Yeah. So if the patient has no strength to hold like a typical MDI inhaler, adopting the use of a spacer will minimize the coordination, so that the patient will not need to hold the breath so long. And because the inhaler medicine is actually trapped in the spacer, the patient will just need to breathe in slowly about 4 to 6 times via the spacer. I can do a simple quick demonstration so that everyone can understand the difference. Okay, give me a minute. So I have a Placebo with me. So this is like a fake inhaler. So before you commence, so let's say if you just prescribe with a new inhaler from the box, you actually need to press 2 times to actually prime the inhaler. After that, you have to shake. Okay, so because it's a propellant, you have to shake to blend it well. So before you even commence using the inhaler, you actually need to exhale first, which is breathe out. Okay, so you have to seal your mouth tight over the mouthpiece, and then you actually have to press and hold at the same time. So I'll do a simple demonstration so that you can visualize what I'm trying to show you. What is it about? Okay, so what are some of the common mistakes which our patients do is, let me show you so that you can understand. Some of them, they'll even, so all these are actually wrong. Okay, so just to let you have an idea. Okay, so you have to shake again, breathe out. Okay, so this is the first puff, first inhalation. Second puff, you have to shake again. Okay, so a good breath hold will need about at least 10 seconds, okay, or hold as long as possible. So let's say if you're an elderly patient, whereby their lung strength, the lung capacity is not there already, adopting the use of a spacer will help to minimize this kind of coordination. So how to use an inhaler with the spacer? So again, you have to shake. Okay, so you can see actually the shape of the inhaler is actually like a rectangular shape, which is actually the same shape as to the back of the spacer. So you have to shake and then you connect to the back. Again, you have to blow out, exhale. Okay, so if it comes with a mask, the mask will fit
You need to fit it firmly from around the bridge of the nose to the jaw of your mouth. Okay, but mine doesn't come with a mask. So if your mask doesn't come with, if your spacer doesn't come with a mask, you need to have a good seal over the mouthpiece. So you breathe 4 to 6 times via the spacer. So the second puff, you have to take it out and shake again. And then you breathe out again. So what most patients do is, what the wrongs of the inhaler technique is, they immediately like that. So all these are the wrong steps. So we need to actually advise and teach our patient what are the right steps, how to use it properly, so that they get the medicine delivered deeply into the smaller airways on a daily basis. Hope everyone get it right. Thank you.
Thank you very much, sister. I must say that sister has been very, very helpful in sharing with us, the different mistakes that some of our patients make. Sometimes we give them the best inhaler for their condition, but if they don't use it properly, then the medicine becomes ineffective. And I think as shown, older adults tend to prefer using a spacer. To use the inhaler directly requires a lot of strength to inspire. So if you have the spacer, they can take, instead of one big deep breath, they take 4 or 5 smaller breaths, and that's a lot easier. All right. So I thank everyone for your time. I think this is very well. I'm very happy to see so many audience members out there and so many questions and such a lively, question and answer session. We would like to have your feedback. So we would love for you to fill out the feedback form. I think our secretariat will send the link shortly, but there's the feedback form on Form SG. We hope to have your support in filling up the form and giving us feedback about our webinar and how we can improve it. So just a last message for everyone. It's never too late. It's never too early to stop smoking and to get tested for COPD. I wish everyone a pleasant weekend ahead. Thank you very much. Thank you, everyone.
Sorry, I